talk today about our practice and our new protocol in NGHA Riyadh. And I will try to be fast because I know we are short of time. So the first thing, our project, our objective, it will be summarize the principle for the use of ATG, allogenic stem cell transplant, and we will discuss the most common side effect of the ATG infusion, and we will talk about our new practice and the guidelines to minimize the IRS related to ATG, and also we will tell you our outcome of our new ATG infusion practice. Introduction, the first thing we will talk about the ATG. ATG is the polyclonal immunoglobulin that affects the human T lymphocyte and has been used for adequate plastic anemia, and also we use it for prevention of the GVHD and even treated of the GVHD for allostem cell transplant. As we said, the ATG is an antibody preparation derived from the rabbit or horse hyperimmunized with a human thrombocyte. And the ATG is so important in vivo T cell depletion strategy, which is reducing the graft versus host disease in HLA match or mismatch donor allografting. Uses of the ATG, as we said, treatment of GVHD, and also prevention of the graft versus host disease, pre or post stem cell transplant medication. It will be suppress the donor T cell to minimize the recognitions of the host cell as foreign. And also we give it as part of the conditioning, which is to prevent the rejection component of the conditioning regimen, and it will be eradicate the host T cell to allow acceptance of donor cell. ATG infusion, as you know, always, ATG infusion has the reaction. It doesn't matter whatever you run it, it will have a reaction. It can be mild, it can be moderate, and it can be severe. The most common, actually, side effect, fever, chills, hypotension, hypertension, tachycardia, and there is nothing well documented the strategy. The labels is saying to you to give as a pre-medication, antihistamine, acetaminophen, and corticosteroid, and will tell you run it over 6 to 8 hours. But usually, most of the time, if you run it as what the label said, even when you are giving the pre-medication, it will be end with the reaction, and sometimes it will be, as we said, moderate or severe, which leads to interruption for the treatment or discontinuation. This is the most side effect. I put this schedule just to see the percentage, how it is high. The fever, more than 63% patients, they will encounter fever. Chills, leukopenia, pain, headache, abdomen pain, diarrhea, hypertension, nausea, thrombocytopenia, peripheral edema, dyspnea, all the side effects like anaphylactic sometimes. Infusion of ATG, it's challenges, and it's a significant number of patients can have reaction. As we said, it can lead to discontinuations or delay of the therapy in some. The symptoms and signs of infusion reaction can lead to an additional investigation. As we said, 63%, most of the patients, they will have fever. Of course, if you have a fever patient, you will go directly to investigate the reason why he has a fever. You will looking for the etiology, infectious etiology. Then you will give as IV antibiotic as empirical, which is costly. This will more cost. In addition, pre-medication, as we said, acetaminophen, antihistamine, and steroid has been used to decrease the risk of reaction. And as we said, the labels is saying the first infusion over 6 hours, and then over 4 hours for subsequent infusion as tolerated. However, these measures reactions still occur, highlighted that need for another structures. In our study, we found one abstract. He was evaluated the rate of infusion reaction. From 2004 till 2012, they were finding it's increasing the reaction. It's reached 93% between 2010 till 2012. And most these patients, even they was pre-medicated, they require another doses of steroids. So the ATG, as we said, is given mostly in stem cell, is part of the conditioning, as we said, to prevent GVHD. Such as reaction can lead to undesirable treatment interruption and the reduced patient satisfaction. And there is reported an incident more than 90% reaction with standard infusion time. Even measures to reduce the reaction are needed. There was so clear we need to investigate to optimize the administration method, as such reactions are associated with morbidity and increased healthcare associated costs. As you see, we said, ATG is part of condition. You cannot stop the conditioning. It will be destroy all the treatment plan. So what is our strategy? To migrate such reaction is to prolong the infusion time. There is a very few reported has been published using this strategy. Reported on their experience after changing the infusion protocol of ATG over 20 hours instead of 4 to 6 hours. However, it was very limited because the number of the patient, it was only 28. So in our institution, the ATG was infused over 6 hours. This was 2011 till 2015. When we noticed each patient, single patient, he has a reaction. So we have to sit and find another solution, how to reduce the reaction. We report our experience and outcome of the people, of the patient receiving standard or prolonged infusion time, and discuss the possible predicate for such reactions. Actually, our experience, the new experience, our new protocol, we already posted as a poster in 2020 in nursing, EBMT, and even one of my consultants, he was also, he presented our experience in 2021 in EHA, and the last one is our hematology journal, one of our consultants also, he posted our experience. So this is the method of how we improve the ATG, or to decrease the ATG reaction. We said all this is physician, IBR approval, it was from the physician, pharmacist, nursing, and the quality. Patients that underwent stem cell transplant from 2011 to 2020, and they were received ATG were included. It's 74 patients, actually. From 2011 till 2015, the ATG was infused over 6 hours, while from 2016 till 2020, ATG was infused over 24 hours. We are splitting the dose in 2 bags. Each dose was running over 12 hours. This is, as we said, our infusion protocol. ATG, we changed it to be infused over 24 hours, 2 bags, over 12 hours. And all the patients will receive as pre-medication every 6 hours, acetaminophen and antihistamine and corticosteroid and steroid, which is plus we wrote as a PRN in case of reaction. We evaluate the infusion reaction associated with the use of ATG in the 2 populations. We make it as one group, 6 to 12 hours, and the other group for 24 hours. Reaction occurs in all patients receive the standard infusion with over 50% considered moderate to severe, which lead to premature discontinuation of infusion in a high proportion of the patients. As we said, you see from over 6 to 12 hours, most of the patients, they have reaction. 50% of them moderate to severe. And you will see, I will show you the table, how many percentage we already stopped the treatment and or delay the treatment or reducing the dose. In this prolonged infusion group only, which is 24 hours, we have only 29% develop reaction. And it's only actually one patient, which is 2%, it was moderate to severe. Nearly half of the patients require urgent evaluation for their reaction by critical care response team, and 27% require ICU admission. We are here talking about the standard, which is 6 hours. Okay, so the patients, we have 27 of them activated CCRT, and 27% they require actually ICU. Comparing to the long duration, which is 24 hours, it's only 2% require CCRT and 0 required ICU admission, respectively with the wrong infusion. Having higher ALC before the infusion was associated with a significant risk of an infusion reaction. Actually, which is the absolute lymphocyte count. This is when our data, we found this. But this now we are working on this to know what is the rule, why if they have acute lymphocyte, they have more evidence to have reaction. So patient receive infusion has significantly high number of any infusion reaction as well as a moderate to severe. Activation critical care and transfer to ICU unit was significantly higher in the short infusion group. Interruption or discontinuation of ATG infusion also significantly more frequent in the short infusion time. Time of neutrophils and platelet re-engraftment, as well as indicate of cytomegalovirus reaction require preemptive therapy, was the similar. Because we look for all the variables, we even check if it will be effect on their engraftment or if they will have more infectious like CMV infection. In multivariable analysis for the infusion reaction, the only thing, as we said, the acute lymphocyte count was predicted within more than 5.9. So this needs more work on that. As we see, you see our characters in our analysis data. It was a diagnosis, what is their diagnosis, the ECOG, the conditioning regimen, the TBI, if even the type of the donor, the stem cell source, and the ALC. If you see, here you will find it. The standard dose, but actually our number of the patient, it was 74. 11 patients was 6 hours and 63 was 24 hours. First of all, why it's just different numbers? Because actually we expand our service after 2015, because that you will find it's longer, bigger number for 24 hours infusion. And actually we decided that in beginning in 2015, we changed our practice for 24 hours. If you see more the age, actually, we took the median age 20, but for the prolonged, it was because more patients, we higher in this study, 35 patients. The malignant disease also, it's 41 in prolonged, and the standard infusion only 4. Non-malignant 7, which is mostly, we use it, as we said, for aplastic anemia, and in the prolonged, 22. ECOG 1, and 0 in the prolonged infusion. The one, even the stem cell also make current TBI, as we said. Look to the reaction. This. For standard infusion, we mean 6 to 12 hours. From the 11 patient was reacted. So we have 100% patient reacted. But in the prolonged infusion, from the 63 patient, only we have 18 patients. So it was 29% only reacted. Moderate to severe reaction, in standard infusion time, it's 6 from 11. That means 55%. But in the prolonged infusion, we have only 1 patient, which is 2 5%. CCRT activation, 5 patients was activate CCRT, but in the prolonged infusion, it's only 1 patient, who is the same patient who has moderate to severe, which actually this patient, he has like chest fungal infection because that he was really deteriorated more with the ATG infusion. The ICU transfer, it was 3 patients required to transfer to ICU, but in a prolonged infusion, we have 0 patients transferred to ICU related to ATG infusion reaction. ATG held 7 patients from 11. That means 64 patients was held. Some of them for a few hours. Sometimes we delay for the next day. But in the prolonged infusion, it was only 8, which is 13%. And it was because the nurses was misunderstood. They just hold it when they found the patient. He had like chills and rigors. But nowadays, since 2020 till 2022, actually, we have only 1 patient was reacted. But from 2020 to 2022, we have never really have any, we don't encounter any reaction. And ATG discontinuation, as we said, 5% from the 11, that means 45, it's a big number. But from prolonged infusion, it's only 3 and 5 of the 5%. Time of the ANC engraftment, as we said earlier, it doesn't make any difference. 19% from the standard infusion, prolonged infusion 14. That means it doesn't affect on the engraftment time. CMV activation also, again, the same thing, because that means ATG, it doesn't affect on that. Our conclusion of this, we found it prolonged the ATG infusion, timely significant, decrease the reaction, which is leading to lower treatment, interruption, or discontinuation. Importantly, severe reaction or the need for critical care service was almost not seen in the long infusion group permitted smooth administration of the conditioning regimen. Reaction were also independently increased with the higher ALC, E level. These observations were not further validation. Consciousness-based recommendation by experts. This is in general and all over the world, even in PMT. It was thinking the infusion of rabbit ATG was published. The decrease of reaction, pre-medication with steroid and antihistamine, acetaminophen are recommended. And in addition, prolonged the infusion more than 12 hours was highly recommended. Our colleague in pediatric, they ran it in 18 to 20 hours, but the whole dose. For us, we are dividing the dose in 2 bags, and we run it over 24 hours. We believe that the infusion of the ATG over 24 hours by using 2 bags, each being infused over 12 hours, is an effective method and as associated with a better safety profile with the less morbidity and mortality. Thank you.